Hi, and welcome to today's case discussion. This is our first case for today. So what we're going to do today is we are going to discuss 10 interesting radiology cases. These are useful for your radiology board exams, for your MD and DNB exams. You can also use them for FRCR or the European diploma exams. What we'll do is I'll show you a typical case of an image, and you can answer in the comments section. I'll wait for some time for people to chat in. For those who are new here, my name is Dr. Amar Udare. I am a radiologist currently doing a fellowship at McMaster University, Canada, and I welcome you all to today's case discussion. Today we'll discuss 10 cases and a few important points related to that case. We're not going to go in detail in the description. We'll try to keep it short so that we cover more cases in a shorter period of time. Okay, so we have a few correct answers already. So most of you have got it right. So what we see here, so these are T1. Okay, let me just switch on my pointer. Okay, there it is. So we have this homogeneously enhancing lesion in the right frontal region. Just give me a sec. I need to switch on. So we have this near homogeneously enhancing lesion in the right frontal region. There is mild perilesional edema. On T1 weighted images, it's iso-intense to the brain parenchyma. There is associated dural enhancement, which is also known as a dural tail sign. This is a classic picture from a meningioma. So the findings, as we discussed, homogeneously and intensely enhancing extraaxial lesion. The diagnosis is a right frontal meningioma. Key points about meningioma: these are most common primary intracranial neoplasms. In which condition do you get multiple meningiomas? So there are a couple of conditions where you can see multiple meningiomas. So the answer, as almost all of you have mentioned correctly, is neurofibromatosis 2. So neurofibromatosis is a commonly placed case in the exams. There's a nice article which I wrote covering all everything about neurofibromatosis. I'll leave a link to that in the description. So it's important to remember that the dural tail may not be seen in all cases. It's seen in about 60% of cases. Differentials include dural metastases, lymphoma, and granulomatous diseases such as tuberculosis and sarcoid, and less likely hemangiopericitoma. Let's move on to the next case. So today we're going to discuss a mix of cases. Mainly it's neuroradiology, but I've thrown in a couple of other systems just to break the monotony. So this is a patient who presented with pus draining onto his skin in the right lower quadrant region. So this is a sinogram image. We have injected contrast through an opening on the skin, so a sinogram or a fistulogram. And we are seeing that the contrast is extending from the skin into what looks like a small bubble loop. So this is, as most of you have rightly pointed out, this is a enterocutaneous fistula. Anil says it could be a peritoneocutaneous fistula, could be, but if you see the configuration of the contrast in the abdomen, it looks more like a bowel loop rather than free peritoneal spill. So this was a case of an enterocutaneous fistula, and this patient had Crohn's disease. Key points: the common causes of these fistula are patients who have undergone abdominal surgeries, Chronic inflammatory bowel diseases, I've seen most of these in Crohn's. They can also be seen in tumors and less likely in the radiation enteritis. Uh, uh, More of a medicine question and less, not much related to radiology. What's the difference between a sinus and a fistula? Oh, so a fistula will have two openings. So for example, as we saw in our case, one opening is onto the skin and the other opening is in the bowel, while a sinus will have blind one of the opening, like you'll only have only one opening. So that's the difference between a sinus and a fistula. So as most of you have pointed it out, sinus is blind ending. An important practical point is that if you're monitoring cases on CT and if your tech comes in with a request saying that the clinicians are suspecting an enterocutaneous fistula, you should put a small amount of diluted contrast in the external opening. We can do that using a non-traumatic needle. So normally we have an IV catheter with a needle. So you remove the needle and the outer plastic sheath can be used to inject. So that is just a plastic sheath and that's non-traumatic, but it's stiff enough to go into the skin opening, and you can inject dilute contrast. Don't inject, contrast directly because that'll cause a lot of streaking, but you can inject a small amount of contrast to delineate the tract of the sinus or fistula. So that's a practical tip for say a CT sinogram or a CT fistulogram. Move on to the next case. So this patient presented with headache, fevers. So there are a couple of findings, so make sure that you mention both these. So Marwa, Sayan, Stuti, all of you have rightly pointed out the diagnosis. So what we see here, there is this solid appearing lesion in the right cerebellum. This is a T2 weighted image. There is perilesional edema, and the lesion, most of it appears hypointense. Usually pathologies are fluid rich, so they appear hyper intense, but very few pathologies can also appear hypointense. This is one of those, so that's a key point to remember. It shows peripheral ring enhancement. There is additional enhancement along the leptomeninges, and as you see here, there's hydrocephalus with periventricular ooze. So this is a case of a tuberculoma with tuberculous meningitis. CNS tuberculosis commonly presents as tuberculous meningitis, and that can give rise to hydrocephalus. The hydrocephalus in cases of tuberculosis is a communicating hydrocephalus because the ventricles themselves communicate, but the drainage into the arachnoid system is impaired. We have discussed hydrocephalus in one of our previous lectures. I'll leave a link to that in the corner and in the description section. As we discussed, in 80% of the cases, tuberculosis presents as meningitis, and in 20%, these present as tuberculomas. They are solid and caesating to begin with, and in this stage, they appear hypointense on T2, while in the later stages, they can liquefy. Say, for example, if you see this portion of the lesion is T2 hyperintense. MR spectroscopy, although spectroscopy is not done everywhere because it consumes a lot of time, so it may not be of that value, and often the findings overlap. But tuberculomas can be confused for a tumor, and in this case, spectroscopy can be used as a problem-solving tool. So, what is the typical spectroscopy finding in cases of tuberculosis? Yes. So, as all of you have pointed out, an elevated lipid lactate peak, predominantly lipids, is very characteristic of tuberculosis. The other important finding is decreased NAA. So remember that N-acetylcysteine is a product of normal brain metabolism. So any pathology that is not does not have brain tissue itself will have decreased NAA. So for example, metastasis. Metastasis, I remember, is unwanted guests in your place. So whenever you have metastasis in your brain, they don't belong in the brain. So they are just like these unwanted guests do not belong in your house. So you'll try to react to them. So metastases are associated with significant perilesional edema. Perilesional edema is not specific, but if the edema is more than the lesion size itself, that's a good clue that this could be a met rather than a primary brain tumor. So an unwanted guest will not have characteristic of the people who live there. So NAA, N-acetyl aspartate, not N-acetylcysteine, so apologies for that. So N-acetyl aspartate is a normal brain metabolism, so you will not see NAA in cases of metastasis or any other foreign tissue in the brain, just like tuberculomas. So decreased NAA and increased lipid due to necrosis are characteristic of tuberculosis. So hope this helps you recognizing these lesions and mets on spectroscopy. So another pediatric kind of neuroradiology case, we have a flare axial and a non-contrast CT. For those who are new today, welcome. And for those viewers who have been joining us for these sessions regularly, thank you for joining in and attempting all these answers. I'd request everyone who's attending and even those who are watching this later to attempt these questions so that even if you're wrong, it's perfectly fine. If you make a mistake right now, you'll tend to remember this for a longer time. So it's okay to do mistakes now rather than in, say, clinical practice or in your exams. So if you're attempting it later, you can answer in the comment section or you can write the answers on a piece of paper and check them as we discuss these cases. For those who are for those people who are attending live, make sure that you try to attempt all answers. It's okay to be wrong. Okay, so let's discuss this case. So what we see here are these multiple cortical hyperintensities, flare hyperintensities, and on the CT we saw a couple of calcified nodules along the ependymal surface. So multiple cortical hyperintensities and these calcified subependymal nodules, these are characteristic for tuberous sclerosis complex. Tuberous sclerosis is characterized by non-malignant hematomas at multiple places. It's one of the common phacomatoses. The triad for tuberous sclerosis is facial lesions, that is adenomata sebaceum, seizures, and mental retardation. Cortical tumors are seen as these flare hyperintense lesions in the cortex. They may be difficult to appreciate on CT images. These may calcify, so progressively in the early stages in infants, these are non-calcified and they progressively calcify. The other finding is subependymal nodules. Subependymal nodules, these can enhance, and enhancement is not a sign of malignancy. In later stages, these can also calcify. The important thing to look out for in a case of tuberous sclerosis, and that needs follow-up, is SEGA. SEGA is subependymal giant cell astrocytoma, and the key point to remember is that enhancement in a subependymal nodule is not important, but increase in size suggests malignancy and transformation to SEGA. So remember that enhancement in a subependymal nodule could be normal and expected, but if there is increase in size, that is concerning. What's the typical location for a subependymal giant cell astrocytoma? Most lesions are seen at a very typical location and they present with a particular symptom, a particular pathology. So yes, as Ayush and uh, Ala, I think you meant foramen of Monro. So yeah, so as most of you have pointed out, the most common location is foramen of Monro. So subependymal nodules in the region of foramen of Monro, you need to look for carefully to rule out conversion to subependymal giant cell astrocytomas. We can also see white matter lesions, which are often closely related to these cortical tubers, but they may or may not be seen. There are other vascular associations and multisystemic involvements in cases of tuberous sclerosis, but we can discuss them in another lecture. Again, just to deviate a little bit, we have a thoracic case. So this is, say, a section at mid-thorax level. The site of origin is difficult to identify on a single image, and to be honest, even for me, if I was given this case, it would be difficult to identify the exact site, but the pathology is very characteristic, so we'll talk about that. So Jyoti had mentioned for the prior case chordothalamic groove. I'm not sure about that, but foramen of Monro is the typical location for subependymal giant cell astrocytomas in cases of tuberous sclerosis. So as most of you have rightly pointed out, this is a case of teratoma. So we see a complex soft tissue lesion in what appears to be the right hemithorax. I assume it could be the right pleural space, or could be the right aspect of the mediastinum. There are multiple foci of calcifications, few areas of fat, and few cystic or fluid density areas. So this was a case of teratoma. So what's a teratoma? Teratoma are germ cell tumors with all three layers, tissues from all three layers, that's endoderm, mesoderm, and ectoderm. Common components include fat, cystic spaces, which can be due to mucin or other secretions, calcifications, or sometimes if you can also see frank teeth formation. Common locations are ovaries, testes, mediastinum, and in the sacrococcygeal region. A differential for this is fetus in fetu, but in that case, the organs would be more well formed rather than just not so well formed soft tissues as in cases of a teratoma. So again, fetus in fetu is a very rare pathology. Most commonly, if you see such a complex lesion, you should be thinking of a teratoma. Yeah, so few people have also mentioned hair, thyroid tissue. Yes, you can see everything. In cases of ovarian teratomas or dermoids, you tend to see all these complex soft tissues, hair and teeth, especially on ultrasound. So yeah, most of you have got this one right. Another CNS case. This was a 6-year-old boy who presented with seizures. So not only the imaging, but the history is also important. So this is a 6-year boy, and so these are the important points in history. So even before you look at the images, the history is a very characteristic. So what most of you have got this one right. So what we see here is these hyperintense areas around the atria, which are bilateral and near symmetric. The region which is close to the ventricle is hyperintense, while the slightly peripheral portion is not so hyperintense, and that portion shows enhancement. So if you see this corresponding area, these don't enhance, but the slightly more peripheral areas enhance. So this is very characteristic for X-linked adrenoleukodystrophy, as all of you have rightly pointed out. So bilateral periatrial hyperintense areas with enhancement is characteristic of X-linked adrenoleukodystrophy. Because it's X-linked, it most commonly affects males, and females are mostly carriers of this disorder, and they are less commonly associated. It's the most common protein or enzyme deficiency to present in childhood. The imaging appearance, as I described in the images, like when we were discussing the MR images, follows that of the pathophysiology. These demyelinating areas consist of a central core, which is periatrial, and that is a dead core. That's a necrotic region that does not have any inflammation. The intermediate zone is the active area, which is slightly less hyperintense on T2, and the peripheral portion is demyelination, but that does not have inflammation. So the imaging follows the pathophysiology as in most cases. Subcortical fibers, I think they are spared in these cases. Cyan mentions that these could be Schromberger's zones. I'm not aware, I'll have to read about that. But yes, so as Arushi also has rightly pointed out, see, the leading edge does not enhance because it's demyelination without inflammation. The intermediate zone is the one that enhances because that's active in demyelination with inflammation. It's posterior in 80% of the cases versus Alexander, which is a frontal predominant leukodystrophy. How do I remember this? X comes in the end of the alphabet, so it's posterior. Alexander, if you remember, was a Greek leader, Greek king. So leaders are always in the front. So imagine an army of soldiers. They are always led by their king. So the king is in the front. So that's how I remember that Alexander's is a frontal predominant leukodystrophy, while X-linked, because X comes later in the alphabet, that's more posterior. You can have your own mnemonic, but this is just something that I find useful. Breaking the monotony of these cases, this is a very nice meme that I came across on Twitter. That's how my last week has been. I was on call and reporting all kinds of CTs. I think it's maybe because of the pandemic that we are getting like patients are presenting with worse findings, and because I work at a oncology center, that's how my last week has been. So just some humor to go with all of complex radiology. Let's move on to the next case. So this is a prenatal scan. I know ultrasound is very difficult to diagnose on single images, and it's perfectly fine if you don't get these. Typically, when in clinical practice, you'll have you can scan the patient yourself and in multiple planes, so it's perfectly fine if you don't get this. I've tried to show a very characteristic image, and most of you have got this one right. So what we see here are fused thalami, fused heart-shaped thalami with a large single ventricle, and there is no midline falx. This was the case of A-lobar holoprosencephaly. So holoprosencephaly is a spectrum of anomalies characterized by incomplete separation of cerebral hemispheres. A-lobar holoprosencephaly is the worst form and is usually fatal in most cases. A-lobar holoprosencephaly is associated with craniofacial anomalies, which can be very weird. For example, they can be associated with a single orbit. They can associated with a soft tissue protruding in the midline, which is also known as proboscis. All these are very rare anomalies, and the patients, they are usually fatal. You don't see them survive long term. An interesting say an MCQ type, a multiple choice question in which you may get asked is what is the most common syndrome associated with holoprosencephaly? So that's a very interesting point that Ayush said, that the face predicts the brain. That's interesting. That's a nice way of remembering that. A corollary to that would be what you speak predicts the brain. So make sure that you speak what you mean. So trisomy 13 or Patau syndrome, I'm not sure about the pronunciation, but trisomy 13 or Patau syndrome is associated with holoprosencephaly. So lots of interesting answers in the chats. So yeah, third eye, cyclops, yeah, all kinds of weird stuff all sorts of weird craniofacial anomalies are associated with holoprosencephaly. So this is a normal variant. This is a 3D reconstruction, a volume rendered image of an abdominal angiogram. This is a normal variant that I want you to pick. So this is the abdominal aorta, this is the vertebral column. So it's an oblique sagittal reconstruction. So what you see here is that the superior mesenteric artery and the celiac artery are arising from a single trunk. So this is a celiaco-mesenteric trunk, which is a rare anatomic variant, although this is not of any clinical significance. But when you're reporting, say, pancreatic cancers, patients with who would go for hepatic transplants, renal transplants, or any kind of complex abdominal surgeries that involves vascular reconstruction, make sure that once you have reported and described the findings, you describe anatomical variants, if any. This is particularly important in cases of pancreatic cancer. So do mention if there is a replaced hepatic artery or a replaced right or left hepatic artery or any of these variants. Among all variants, the ones which I commonly see are replaced hepatic artery or a replaced left hepatic artery. A celiaco-mesenteric trunk is rare. Rarely there can be a celiaco-bimesenteric trunk where both the mesenteric arteries are arising from a common trunk. So this is again a neonatal neuroradiology case. These are eggshell sections of a neonatal brain MRI. I'll give some more time for this because these are usually complex and require more time. And while you're answering this, I would request all of you to pause for a second and give me feedback about the cases that we are discussing and all other radiology resources that I'm putting out. So if you like the content, for all those who are watching it later, and for the live attendees, let's pause for a minute, and if you like this video, make sure that you take the time and hit the thumbs up button. If you don't like the video, it's okay. There's always room for improvement, and that's how I have been improving these. If you look back on our first lecture, and we've done around 30 lectures so far, and it's your feedback that has helped me improve. So if you have any suggestions or if you don't like what we are doing, feel free to hit the thumbs down button. But if you do that, make sure that you mention that how we can improve these. So that'll help all our future lectures. And So any kind of feedback is always welcome. And for those who have not subscribed to the channel, make sure that you subscribe. Subscription is free. Some people have a misconception that subscription on YouTube is paid, but subscription is free. That way you are reminded of all our future lectures, including live sessions and other recorded radiology sessions that I update. So for those who have not subscribed, make sure that you subscribe hit the subscribe button right now. Moving on to today's case. Okay, so Dr. SR is requesting to talk slowly. Okay, so that's a very good suggestion. It's important that you guys understand what I'm trying to say. So that's a very good suggestion, and I was not aware that about this. I'll try to speak more slowly so that all of you can grasp what I'm trying to say. Thank you, Dr. SR. So coming to this case, so what we see here is smooth cortical surfaces. There's not much of gyration, and the sylvian sulcus is quite shallow. So this, apart from this, there is a thick band of deep gray matter, and the ventricles are slightly larger in size. So this was a case of lissencephaly and band heterotropia. So lissencephaly spectrum consists of agyria, which is very rare. Commonly we see is pachygyria, that is less. So pachy means less gyria. I'm not sure what the word pachy means. I don't think it means less, but pachygyria is a slightly less severe variant, and bad heterotropia. So heterotropia is heterotropic brain tissue, which is commonly seen around ventricles. So heterotropic gray matter. It can be seen as nodular areas. We have discussed that in one of our prior lectures. And if it is in a band form, it is known as band heterotropia. The word listen means smooth, so that's a nice way. So if you remember these terms, so what happens is that many of these terms are old age terms. They have been given, say either they have a Greek or a Latin origin. If you remember these terms, the meaning of these, it's easy to remember the pathology. So listen means smooth. So Allah has rightly pointed out, now I remember. So pachy means thick, and thanks for reminding. So probably that's because the gyri appear thick in these. The gyri appear thick. That's why this is known as pachygyria. And apologies if I said that there is lack of gyri. So there's lack of sulcation. I don't remember if I said lack of gyri. So there's lack of sulcation, which is characteristic of lissencephaly, which means the word listen means smooth. This is associated with callosal abnormalities, and the appearance sometimes is also known as a figure of 8 appearance, especially on CT, because of the shallow sylvian fissures. So that's kind of a tongue twister there. Coming on to today's last case. So neuroradiology, especially pediatric neuroradiology, is a difficult topic, and it's a specialty in itself. It's easier to talk about the common disorders, and that's how, if you're a general radiologist, that's all that you need to know. But if you dive into the lesser common variants, it's a very vast specialty. What I tend to do is I remember the common variants, and if there is say an uncommon variant or a rare abnormality, I have to read up about them. It's difficult to remember everything, especially if you're a general practitioner. Okay, so all of you have pointed it out right. So this is a Dandy Walker malformation. So the posterior fossa is large. There is a large cyst communicating with the fourth ventricle, and the venous confluence, which would probably be here, is higher than the expected location. That's typical of a Dandy Walker malformation. So Dandy Walker Continuum is a spectrum of anomalies that includes Dandy Walker malformation, Vermian hyperplasia, Blake pouch cyst, and megacisterna magna. So this is a separate lecture where we can discuss all this in detail, but it's very difficult to discuss it in 5 minutes. But remember that this is a spectrum of anomalies, starting from the most severe form, that is Dandy Walker malformation, to the most benign form, that is megacisterna magna. And the symptoms are mainly related to the amount of Vermean hypoplasia. So in cases of Dandy Walker malformation, there is significant Vermean hypoplasia, and in cases of megacisterna magna, there is hardly any. It's the most common congenital cerebellar dysplasia. The posterior fossa is large as compared to say something like a Chiari 2 malformation, when the posterior fossa is small. A typical sign that is described and is specific for Dandy Walker malformation is that the sinus confluence, so if you imagine this to be the confluence of sinuses, this is higher than the location of the lambdoid suture, what is known as a lambdoid torcular invasion. So the confluence of sinuses is also known as torcular herophili, again probably a Greek term, but if that is located, that's normally located inferior that's located inferior to the lambdoid suture or at the same level. If it is, so what happens in Dandy Walker malformation, that there is this large posterior fossa, so the sinus of confluence is elevated, which gives rise to this sign, which is known as lambdoid torcular inversion. Another important measurement which they have described to distinguish each of these pathologies is the Tegmentovermian angle. Again, this is delving deeper into this pathology, but all of you may not require this. Just to remember, if I would allow to touch over it. So this angle is the Tegmentovermian angle. So just imagine this, for example, this is the normal cerebellum. So the Tegmentovermian angle in this cases will be small. As the vermis becomes more and more hypoplastic, it moves, this posterior fossa cystic lesion displaces the vermis superiorly. So what happens is that this angle becomes wider. So let's say this is a normal Tegmentovermian angle. Because of the cystic posterior fossa lesion, what happens is that this angle increases, and this, so for example, again, this is also responsible for the lambdoid torcular inversion. So a larger Tegmentovermian angle is associated with the more severe forms. So for example, Dandy Walker malformation will have the least amount of cerebellar Vermean tissue, so that will have the highest Tegmentovermian angle. So it's a difficult topic, but I've tried to simplify this, and you can read more about this. But this angle will help you to distinguish with these pathologies and with their other routine findings. Yes, it can be detected. So Dr. SR, you can, as you rightly pointed out, this can be detected in an antenatal ultrasound, say in a sagittal image, or also in cases of if there's a fetal MRI, you can see this on a fetal MRI. I don't remember the exact value, but I think if it's more than 45 degree, as a few of you have pointed out, that is typical of Dandy Walker. One more a caveat is that these things, these numbers, these angles, it's not possible to remember all of these, especially if you're not reporting, if you're a general radiologist reporting everything. It's okay not to remember. If you don't remember this, if your examiner asks you, exams are stupid. They can ask you anything. They don't emulate your clinical practice. So if you don't get these in your exams, it's perfectly fine. Especially now that everything is available on the tip of your fingers, it's okay not to remember these angles. It's more important to remember what's happening and what's the pathophysiology. Okay. So just a quick recap of the cases that we discussed. We discussed a meningioma and the typical appearance of a homogeneous enhancing extraction lesion. We discussed an intracutaneous fistula and a practical tip on how to do CT fistulograms. We discussed imaging of tuberous sclerosis, CNS tuberculosis, and tuberous sclerosis. We discussed a teratoma. We discussed X-linked adrenoleukodystrophy and how do we distinguish it from Alexander's disease. We discussed an antenatal ultrasound of A lobar holoprosencephaly, an interesting normal variant in the abdomen, the celiac or mesenteric trunk. We discussed lissencephaly and band heterotropia. And lastly, we discussed Dandy Walker Malformation and Dandy Walker Continuum. Make sure that you don't use the term Dandy Walker variant. The term preferred is Dandy Walker Continuum. And I'd like to thank Dr. Pawan Kumar for these cases. He has a very nice website, radiologsabha.com. You can search it. He has a bunch of cases. He has all prior examination question papers. And so yeah, make sure that you check out his website. So that was our session. Thank you guys. Hopefully you learned a couple of new things apart from the cases that we already discussed. As I mentioned previously, if there's anything that we can improve in this, make sure that you type in that in the comments section. If you like the video, make sure you hit the thumbs up button. And for those who are still not subscribed, subscribe to the channel, and if there's anything that would make you to subscribe, let me know how can I improve these, and that way you can be reminded about all future videos that I put up. Okay, so thank you for all those who attended this session live, and for those who are watching it later, thank you for taking out time and watching this video. There will be more videos. If you want to check out more videos, you can check our radiology channel and our radiology website, that is radiogyan.com, radiogyan.com. Thank you. Have a good day, good night, good evening, depending on what part of the world you're watching this lecture from.